Hi, everyone. Welcome to our Monty-Hart lecture series. Today, we have a great speaker, Dr. Jiwon Kim, who's joining us from Cornell University. Dr. Kim is an associate professor in the cardiovascular division of medicine at Weill Cornell Medical College, where she's the director of the cardiovascular imaging program and co-director of the Advanced Cardiac Imaging Fellowship. Dr. Kim she completed her MD at our own Albert Einstein College of Medicine, and then she completed her residency at Beth Israel Deaconess, and then she did a fellowship at Brown and an advanced imaging fellowship at Memorial Sloan Kettering. Dr. Kim has expertise in clinical outcomes research with funding through the NIH, as well as intramural and extramural grant support. She is the chair of the SCMR COVID-19 Task Force and is the Digital Media Strategies Editor for Circulation Cardiovascular Imaging. And she also serves on the editorial board for JACE and CIRC Cardiovascular Imaging. So it's a great pleasure to have you here today. She will be talking about new insights in the assessment of the right heart. Thank you for joining us.
Thank you so much. Thank you, Leandro, and thank you for the invitation to the Monty-Hart program. It's really an honor to join you and to be able to talk about right heart imaging to such an esteemed group of imagers and cardiologists. So I greatly appreciate the opportunity. So I'll talk today about some new insights into the assessment of the right heart using multimodality imaging sort of focus. So I'll start, as we know, in the recent years, there's been a lot of renewed interest in the right heart, particularly now that there's more evidence that the right heart function is really important for a variety of different conditions, including the ones I've listed here, as well as many others, heart failure, MI, pulmonary hypertension, valve disease, just to name a few. And we know that while there have been a lot of advances, there are still remaining challenges when we're assessing the RV. And I've highlighted several reasons in terms of some of the challenges that we face when we're trying to assess the RV as imagers. The first really has to do with the geometry of the heart. I think we're all used to hearing that the RV has a complicated geometry. And what does that mean exactly? So the RV is crescentic in shape. It has multiple components. There is the inlet that contains the tricuspid annulus. There is the trabeculated apex, and then there's the outlet. So there are three different components to the RV. And because of the shape, there's really no good way for us to develop a geometric model. So the LV we describe as being spherical or helical. The RV, there's not really a great geometrical model that we can identify the RV with. Additionally, those of us that spend time reading images know that the RV is much more heavily trabeculated than the RV. So contouring the RV can be quite difficult, and tracing the RV can be challenging. We also know that the RV is a much more thin-walled structure. So the RV is only about 2 millimeters in thickness. So visualizing just the wall itself and measuring it accurately can be incredibly challenging. The RV, we also know, has many variations in terms of shape and size, depending on loading conditions. So day-to-day changes in the RV assessment can occur, and so studying the RV can be very challenging. And then those of us who read echo know that there's really no good reference point. So it's very difficult for us to know when we're on axis when we're measuring the RV, and we'll talk about that a little bit more as we go forward. In addition to the anatomical differences, it's also important for us to keep in mind that the LV and RV are actually quite different hemodynamically as well. So we can't just apply all the principles of the LV for the RV. For example, we know that the RV is about 10 to 15% larger in terms of volume than the LV. We also know that RV mass and wall thickness is about a third of that of the LV. And so for these reasons, we know that the RV is much better in terms of its response to volume, whereas the LV accommodates much better to pressure. And to go through that a little bit more, we also need to recognize that the RV contractile mechanism is also very different from that of the LV. And to review, the RV myofibers are arranged in two predominant layers. There's the subepicardial circumferential layer that's contiguous with the LV. And then there's the longitudinal layer that this is our TAPC, this longitudinal contraction that occurs that goes from the base to the apex. On the right-hand side is a 3D model kind of demonstrating what that looks like. So it's this kind of peristaltic-like contraction pattern. And the activation starts from the inlet and then ends at the RV outlet or the infundibulum, as you can see here. So comparing the LV and the RV, these are sort of standard echo images I've taken here side by side, the LV, of course, on the left and the RV on the right. And you can see right away the way that the LV contracts is very different from the way the RV contracts. So the RV, so starting on the right side here, you can see is really just contracting longitudinally. So we're contracting from the base to the apex. There's very little radial composition when we're talking about RV function. And the typical twisting and rotational movements that we typically describe with the LV really is not as applicable for the RV as you can see here. And this is why our TAPC and our RVS prime work as well as they do, is because the primary contraction, once again, is this in this longitudinal direction. So to illustrate some of the difficulties in assessing the RV, I've put up three images, three video clips, echo video clips of the RV here. And so I'll give you a minute or a few seconds rather, maybe not quite a minute, to have you take a look and see, which of these RVs do you think is dilated? A, B, and C here. And now, if you thought that all of the RVs was dilated, I think that that's probably the correct answer. And in fact, this is actually the same patient and is part of the same study performed on the same day. So we just had the sonographer make small changes, small adjustments in terms of the transducer angle. And you can see that we're going from what would be considered an upper limit of normal RV linear dimension all the way to severely enlarged RV dimension. And all of this has to do with very small transducer angle. And it's, again, very difficult for us to know, what the maximal dimension is with the images that we have. So really highlighting that RV measurements can be quite difficult, but there are some key points that I hope will make this a little bit easier, and I'll go through that. So first, it's important to keep in mind that when we're measuring the RV in a standard apical 4-chamber view, we're going to get significant variations in RV measurement with the transducer rotation, as I just described. So really the key view when we're looking at the RV on echo is what's called an RV focused view. So on the left-hand side, we have an apical 4-chamber view. That's a standard view tailored to the LV. When we're looking at the RV, we really want to make sure that we're focused on the RV because that's the structure that we're interested in looking at. And we tell our sonographers and our fellows that in terms of some tips to get this RV focused view, your transducer position is more lateral, and you want to rotate your probe until you get the largest basal dimension, and then you know that you're in a good RV focused view. And this holds true not only for RV size, but also for RV function. So it's also important that when we're making our functional measurements, so TAPC, S prime, FAC measurement, fractional area change measurements, we want to be in a focused, in an RV focused view. And the reason for this is because prior studies have shown that when we're in an apical four-chamber view, our TAPC, S prime, and FAC are underestimated. And it's 10. Here you can see S prime changes from 10 to 12 depending on the view, but this can have significant impact in terms of clinical implications depending on what value you're looking at. And so there are major differences that can occur if we're doing these measurements in an apical four-chamber view. So we, again, want to be in a RV focused view when we're making both linear dimensions as well as functional measurements. So in terms of RV focus view, we also want to make sure that we're examining the RV in more than one view. So traditionally, again, we use the RV focus view, but when you look at the ECHO guidelines for the RV, the guidelines actually state that there are 4 additional measures for RV size that we could use, including views in the parasonal long axis. So we can make these kinds of measurements in the parasonal long axis, as you see in the middle panel here. And so we were really interested in testing whether these measurements, these other measurements, in addition to the RV basal measurement, had any clinical implications in terms of, 1, how they performed in relation to a gold standard, and 2, whether these measurements complemented one another when we're looking at these echoes in a standard fashion. So to test whether these measurements were useful, we did a study. This was a multimodality imaging study using echo as well as MRI. In this study, we enrolled about 200 patients who were post-MI, and we made all of these measurements both on echo as well as volumetric measurements on MRI. And you can see here that our findings really show that the greatest magnitude of correlations occurred for the RV basal width. So this is that basal width measurement that we typically make for our clinical echo reading. However, we also showed here that the proximal RVOT width in the parasonal long axis view also had very high correlations in relation to CMR. So here our correlation coefficients are ranging from 0.68 for this parasonal long axis view, all the way to 0.7 for the RV basal view. And the negative predictive value, as you can see from the table below, is actually quite high, up to 97%, but the positive predictive value is lower. And what that means clinically is that when you have a normal linear dimension on echo, you're likely normal. The RV is likely normal. However, if you're measuring a dilated RV, this could potentially be a false positive, and we do need to interrogate that measurement or integrate that measurement with other measurements or perform another imaging modality. Next, we look to see which of these measurements is independently associated with RV volumes. And our findings demonstrate that, in fact, 3 out of 5 of these measurements are independently associated with RV volume. So these findings really do support a multi-parametric approach. So multiple measurements actually can help in our assessment of the RV. And conceptually, this all makes sense. As I showed earlier, the RV is a complicated structure with multiple components. And so just measuring one dimension really doesn't tell the whole story sometimes. So related to a multi-parametric approach, 3D echo is, of course, a very useful tool for RV assessment. And 3D echo obviates the need for a multi-parametric approach because 3D echo allows us to obtain 3D volumes and ejection fraction, and there are no geometric assumptions that we make when we're obtaining 3D echo images. We also know that 3D echo is now really well validated against CMR-derived volumes. There are some systematic underestimation of volumes using 3D echo, and I'll talk about that a little bit more. But 3D echo does provide us with RV volumes as well as stroke volume and ejection fraction, and there are now established reference values that we can use as well. So how do we acquire a 3D RV full volume? This is typically in an apical acquisition. We use a modified RV focus view. We want to make sure that we're including the tricuspid valve, the apex, and the outflow tract. So all three components of the RV. And we want to acquire this in a full volume loop. So we want to adjust the focus, adjust the depth and sector size to really maximize our image quality. And as always with 3D echo, we want to make sure that the 2D image quality is good so that our image quality for 3D is also optimized. So our group and others have studied 3D echo in relation to RV size and function. This was a study I did as a fellow some time ago now, where we did 3D echo as well as CMR in patients with cardiomyopathy. And in this study, we show that 3D echo volumes and ejection fraction actually correlate quite well in relation to MRI. And as you can see here, 3D echo also showed lower volumes in diastole as well as systole, and this has been replicated in studies that followed ours. But the ejection fraction actually was similar between 3D echo and CMR. And this is because of the reduction or the decrease in volumes using 3D echo was proportionally so that the EF was actually similar between modalities. And there are some speculated reasons as to why the volumes for 3D echo may be lower. Some of the hypotheses include perhaps that we're not including all of the trabeculations on 3D echo, and maybe that the RVOT is not being fully included on 3D echo imaging. So now moving on to RV function, I want to share this case. This is our second case to assess some strategies that we can use when we're looking at RV function. So here I have a patient. So this is a 76-year-old with AFib who's had prior CABG, who has an ischemic cardiomyopathy. The EF is 47%. And this patient is being referred for a CABG. And we do the echo, and the echo shows a TAPSE of 1.3 and an RVS prime of 8. And so these are, of course, reduced values. And the question here is the RV function truly reduced? I'll give you a minute to take a look at the images here. And so here, what are we considering? What are some of the considerations when we're trying to assess RV function in patients who've had prior cardiac surgery, who have an ischemic myopathy, and who have AFib? So what are some things that we need to consider here? So this leads us to this very nicely done study back from 2009 now. I think this is a really important study, really demonstrating what happens to TAPSE and RVS prime after cardiac surgery. So in this study, as you can see, after cardiac surgery, TAPSE decreases at 3 months, as does S prime. But there's really no reduction in RV ejection fraction on 3D echo. So TAPSE and S prime decrease after cardiac surgery, but the EF really is unchanged. So it's really thought that TAPSE and S prime changes are really due to changes in the contractile pattern after surgery, not really due to functional impairment itself. So sternotomy, it's thought, could alter longitudinal shortening of the RV, and could cause the radial contraction to increase to compensate. So the overall EF is not so changed, but the TAPSE and S prime may be falsely low. So something to keep in mind when we're reading echoes in patients who've had prior sternotomy. So the same patient was enrolled in a research study with us where the patient underwent a 3D echo as well as MRI. And as you can see, volumetrically, the RV function is very much normal. And you can even kind of visually see that why the TAPSE and S prime may have been low. The longitudinal contraction maybe not quite as robust, but that's made up for by sort of this compensatory radial contraction that occurs. So the RV ejection fraction actually was within normal limits. So when we're looking at measurements like TAPSE in relation to RV ejection fraction on MRI, it's important to keep in mind that TAPSE does have reasonable diagnostic performance. So when we're looking at TAPSE, these are two studies, one by Knight, another from our group. You can see that TAPSE actually has an AUC of about 0.75, which is reasonable. As we'll discuss later, it doesn't perform quite as well as strain and 3D echo as you see here, but it is a reasonable screening tool, which is why it's something that we use on a daily basis. However, as with all measurements, we want to make sure that we recognize the limitations and pitfalls. For TAPSE, we want to be mindful that, again, it's very dependent on angulation. It's also very load dependent. So in severe TR, for example, the TAPSE can normalize. And again, TAPSE is just taking a displacement of a single segment of the RV. So it doesn't encompass the complex geometry of a 3D structure. And as we just discussed in post-sternotomy, TAPSE is not as helpful. And it's also important to keep in mind in PH, there's increased dependence on radial function. And so TAPSE may not be as helpful in patients with pulmonary hypertension. Next, I want to talk about strain imaging because this is an important technique that doesn't require specialized equipment. So we don't need 3D equipment or other equipment to get strain for the RV. So we can do speckled tracking strain using just conventional 2D imaging. And similar to LV strain, strain for the RV takes advantage of the inherent speckles in the myocardium on a routine 2D echo. And we can either do this online while we're doing the echo, or we can post-process these offline as well after the echo has been done. There's a lot of data validating use in terms of LV strain for the LV, less data for the RV, although there's emerging data and increasing data from year to year. There are several, there are many studies now looking at the diagnostic and prognostic utility of RV strain. For example, our group has studied RV strain in patients undergoing CABG on the left-hand side here. We looked at strain in relation to other parameters like TAPSE, S prime, and we show here that RV strain is really the best predictor of perioperative RV failure in patients who are undergoing cardiac surgery. On the right-hand side, we've also looked at strain in the oncology population, working with our hematology colleagues. We've looked at RV strain in patients with cancer, and have shown that RV strain is independently predictive of mortality in patients with myeloproliferative neoplasms. These are patients who are at risk for pulmonary hypertension. And I think these studies really highlight the prognostic importance of strain across really a wide range of conditions. So if strain works really well in predicting mortality and outcomes, how well does strain perform in relation to conventional techniques like TAPSE and S prime? So we systematically tested all RV indices in this multimodality study, and we looked at RV indices in relation to CMR. And directly compared 3D echo and strain in the same cohort. In this study, we show that RV strain and 3D echo really do outperform conventional indices. As I said, the AUC is far higher. But even surprising to me, we found that RV GLS, global longitudinal strain, was actually similar in terms of its performance in relation to 3D echo. And I think these findings really do highlight the strength of strain. Using conventional 2D imaging, we can assess RV function with diagnostic accuracy that's really similar to that of 3D echo, and can provide incremental prognostic value as compared to our conventional indices alone. So to wrap up in terms of echo imaging, so TAPSE and S prime, of course, are readily available and are good screening markers. When should we consider 3D echo or RV GLS? I would say that we should consider GLS and 3D echo when there's poor M mode alignment, as we discussed earlier. Pre and post sternotomy, TAP-CNS prime are not as useful. When you're suspecting regional RV dysfunction, strain can be very helpful. In severe TR and pulmonary hypertension, TAP-CNS prime become less useful, and 3D echo and strain should really be considered in those scenarios. We talked a little bit about RV geometric models in terms of its our difficulty in coming up with a good geometric model for the RV. Unlike the LV, which is thick-walled and ellipsoid in shape, the RV is a crescent like shape and again is very thin-walled. I've highlighted all of the LV geometric models, many of the LV geometric models here on this slide. We have the area length method for the LV. We have the prolate ellipsoid method for the LV. But unlike the LV, really, there are no geometric models that exist for the RV. So our group is really interested in developing an RV geometric model to be able to quantify things like mass and volumes using a 2D echo technique. Presently, there are no robust models. This is a model that we have started working with. It's a quarter ellipsoid model. And using this model, we have shown that RV mass calculations can be performed. So we looked at RV mass calculations in relation to CMR. And we've shown that when we take the RV width, the RV length, and the RV wall thickness, we can use this formula to calculate an RV mass. So we've started looking at this in a wider cohort and also looking at gender and body size cutoffs. So I think this is a really interesting area of research in echo, to be able to take linear measurements and assess volumes as well as mass, similar to the way that we do on a daily basis for the LV. And of course, there's a lot of interest in artificial intelligence as well as machine learning for LV assessment. There's less data for the RV, though there are more forthcoming. This is our group's work. We developed a machine learning approach to assess RV function. So this was a model that tracked the tricuspid annulus, as you can see here in the figure, using a convolutional neural network approach. And this model, we trained 7,791 image frames and performed automated linear and circumferential indices that quantified annular displacement. So this is sort of a poor person's TAPSE, if you will. And we did this incredibly quickly. For those of us who read a lot of echo, will appreciate that 7,791 frames were analyzed in less than 1 second. So pretty impressive using this machine learning model. And then when we looked at the diagnostic performance, we showed that the diagnostic performance actually was quite reasonable, ranging from about 0.71 to 0.73 in relation to CMR. And the positive predictive value in determining RV dysfunction was also quite good using this model. Of course, there's a lot of interest now in developing a full machine learning segmentation tool for the RV, and that's also forthcoming as well. And next, I want to talk about CMR. Of course, CMR is really considered now the reference standard for RV parameters, including dimensions, mass, and function. We can really comprehensively assess the RV without having any restrictions in terms of acoustic windows, body size, and we can get really high resolution 3D visualization of the right heart. There's a lot of correlation data, in vivo correlation data showing high accuracy as well as reproducibility. But I'll highlight that, as I showed earlier, there are a lot of echo tools for RV assessment in terms of size and function. And I think where MRI really adds its value is not for function and size. Of course, it can do that as well, but really the value is in the myocardial tissue characterization when we're talking about RV geometry and function for CMR. We know that there are 2 different types of fibrosis patterns that occur in patients with RV overload. There is the RV insertion type fibrosis with the red arrows, as you can see here. But there's also a mid-wall fibrosis that can also occur here with the blue arrow. This is a patient on the bottom here with both RV insertion fibrosis as well as mid-wall fibrosis. Prior studies have shown that these kinds of fibrosis patterns can occur in more than half of patients with RV dysfunction. And I think a really interesting question is whether these fibrosis patterns will become a marker of irreversible or advanced disease, and whether these can be used as targets in terms of timing therapy. For example, this was a study in 58 patients with pulmonary hypertension, looking at myocardial fibrosis in patients with increased RV afterload. In this cohort, 69% of these patients had these kinds of RV insertion pattern LGE. In this study, the investigator showed that LGE, late gadolinium enhancement, was a predictor of death and right heart failure even over 10 months. And I think these studies really, again, call to question whether we should be studying these fibrosis patterns as a target or marker of disease processes, including pulmonary hypertension and even tricuspid valve disease, and help us guide when to best intervene in terms of timing. This leads us to our next case. So this is a 56-year-old who presents with a late presenting inferior wall MI. This patient has exertional fatigue and has PVCs on the monitor. And you can see these are cine images on MRI. There's clearly an inferior LV wall motion abnormality, as you can see here in these two basal to mid LV slices. And you can see on the delayed enhancement imaging, there is an inferior infarct, as you can see highlighted with the red arrow there. There's an inferior wall MI that's occurred by LGE. The LVEF was 49%, the RVEF was 51%, both lower limit normal and mildly reduced for the LV. But if you look closely at this patient's MRI, you can also see that there's a probable RV infarction as well. It's a little bit difficult to see, but there's late gadolinium enhancement of the inferior RV wall. So for those of you who don't read MRI imaging, on LG imaging, scar and infarction is bright, so it should appear bright as you see here. And we see some areas that are bright in the RV as well, in the RV inferior wall. So this is using our traditional conventional breath health imaging LGE sequence. And then this patient also had what's called a navigator-based sequence. It's a newer technique using diaphragm gating. In our case, we're also trying to develop a new technique to assess RV infarction specifically. So this is an RV tailored navigator sequence. And you can really see the big difference. The inferior infarct here is much more difficult to tell using conventional imaging. And then using this navigator-based imaging, we can see the infarct much more clearly. And using conventional imaging, RV infarct is incredibly hard to tell, RV infarct and fibrosis. But we believe that these sorts of new techniques can help us visualize myocardial tissue properties of the RV. So why do we care about RV infarction? We know that RV function is really important in coronary disease as well. RV dysfunction independently confers adverse prognosis. And we know that the RV and LV are really closely linked due to a lot of different factors, including a common coronary blood supply. And there's direct mechanisms in terms of altered RV perfusion, as well as indirect mechanisms. The RV can be impacted by the LV indirectly through changes in the LV hemodynamics. So again, assessing RV myocardial tissue properties is incredibly difficult because of the thin nature of the RV wall. Again, the RV is only about 2 to 3 millimeters in thickness. And so detecting fibrosis and infarction here can be difficult. We're working on developing a fat navigator technique. So we're trying to track the fat that surrounds the RV and trying to gate to that fat to be able to perform tailored RV infarction imaging. Some preliminary data here in panel B, you can see RV infarction is more difficult to see. Panel A, it's much more clearer, much clearer as you can see. And we also looked at signal to noise ratio as well as contrast to noise ratio, and these levels are much higher using the navigator-based technique for the RV compared to our conventional technique. We can also perform co-localization studies using regional strain analyses. So on the right-hand side are feature tracking analyses using MRI data. And you can see that in these inferior walls of interest, that strain in those regions is lower than in regions elsewhere. So these sorts of techniques can really help us see how these sorts of small infarcts on the RV can affect overall RV function. So this brings us to the concept of targeted revascularization. We often think about viability imaging and targeted revascularization for the LV, but similar concepts are really not thought of for the RV. So this is one of our research patients. This patient has a known total occlusion of the right coronary artery. You can see that there's an inferior LV wall motion abnormality. There's also an inferior RV wall motion abnormality, and the overall RV ejection fraction is reduced both by MRI as well as by 3D echo. And you can see following opening of this RCA CTO, the LV function, of course, improves. You can see that the inferior LV wall is contracting much better, but the RV function overall also improved. And I think this case really highlights this concept that for patients with RV dysfunction and coronary disease, targeted revascularization could have the potential to improve overall RV function, and myocardial tissue characterization of the RV may help us really better select patients who would most benefit from targeted revascularization. And as I told Leandro earlier, we have started looking at COVID using CMR, and to sort of tell you the story of how this came about. It turns out that COVID infection is actually a really interesting model that shows us the complex interaction between the RV as well as the lungs. And I think many of us during the COVID pandemic, especially in the city, we saw a lot of patients who were in the ICU, who were intubated, who had really severe respiratory infection with COVID, with really bad looking RVs on echo. And so this is kind of how this interest in studying COVID started for our group here. And I think COVID infection, as you can see in this diagram, really highlights the impact of ARDS, lung injury, mechanical ventilation, thromboembolic phenomenon, as well as just overall acute illness on RV function. And so it turns out the COVID infection actually is a really interesting model to be able to study the RV in these sorts of very complicated physiologic mechanisms. So this was one of the first studies looking at the RV in COVID infection very early on in the pandemic. This was during the first year of the pandemic. Here in New York City, across New York Presbyterian networks, we looked at the independent impact of the RV on mortality in COVID infection. And here we showed that during the height of the pandemic, 35 patients with COVID either had RV dilation or RV dysfunction. So very high rates of abnormal RVs in this population. And then we looked at the prognostic impact of the RV in these patients and found that RV remodeling, so adverse RV remodeling, conferred a greater than twofold risk in mortality, even after controlling for conventional markers of illness, including elevated biomarkers like troponin, as well as age. So we've started looking now at long COVID and looking at the impact of RV function in long COVID and in patients with ongoing COVID symptoms, looking to see whether there's any impact in terms of RV abnormalities in these patients. And lastly, I want to highlight an additional and emerging value of CMR for right heart assessment. Our group and others are studying quantitative susceptibility mapping, also known as QSM. And this is a way to non-invasively measure oxygen saturation in the right heart as well as the pulmonary artery. So this is a technique, this is an advanced MRI technique. We're looking at magnetic susceptibility to be able to quantify the spatial distribution of magnetic susceptibility in the different chambers of the heart. So here we're measuring magnetic susceptibility differences between the venous and arterial blood pools using QSM. And to do this, we're using a multiple breath-held gradient echo sequence, which are then processed to generate QSM maps. And we're looking at differential susceptibility between the RV and LV blood pool as a result of differences in paramagnetic as well as diamagnetic properties of oxygenated and deoxygenated hemoglobin. And this allows us to measure blood oxygenation differences between the LV, the RV, and the PA. So using QSM, this was a study led by Dr. Spin-Semel, who's a physicist who is a close collaborator of our group. We've shown that CMR can actually discern differential blood pool oxygenation in the right heart. So we can measure oxygenation in the right heart and the pulmonary artery. And we validated this approach in relation to right heart catheterization. So we looked at patients undergoing right heart cath who also underwent QSM, this technique, and showed that blood oxygenation by QSM and right heart cath actually correlated very nicely with a correlation coefficient of 0.87. And we've started using this technique in patients with pulmonary hypertension, as well as in patients with right heart failure. And we hope that in the future, this could be a non-invasive way of assessing oxygenation, allowing us to maybe even forego a right heart cath or use this as a surrogate for right heart cath markers to assess RV as well as lung function. So that brings me to the conclusion slide. So as we showed earlier, the RV has a very unique geometry and functional mechanics. We reviewed that it's a very important prognostic marker in a lot of different conditions. There are many different methodologies for RV assessment. On ECHO is, of course, a great screening tool, but the key is really that RV focus view. And I encourage everyone to use a multi-parametric approach when you're trying to assess the RV in terms of size and function. MRI, again, the real added value is characterization beyond just structure and function and looking at the myocardial tissue properties in terms of CMR and its real strength. And I think allowing us to visualize and better refine assessment of the RV gives us the tools and understanding to be able to improve targeted therapies and improve our understanding of mechanisms. Thanks so much. I'll take any questions at this point.
Thank you very much. What a wonderful lecture, and I'm sure everyone liked it as much as I did. And let's proceed now with the questions. So if you have any questions, please put it in the Q&A or the chat, and we'll go through them. I think Dr. Garcia is with us. We're going to start with the first question.
Well, first of all, congratulations, Jaewon. This was the best lecture I ever heard about the right ventricle. So amazing.
That's so kind.
What a work you've done. But I have one question. I always struggle to what to say when there is a significant afterload mismatch for the right ventricle. Obviously, the scenario that we're talking about is primary pulmonary hypertension. The range of afterload for the left ventricle relatively is very limited. So when you develop pulmonary hypertension, your pulmonary vascular resistance, it can go 3-4 times normal values, and a decreased TAPSE or a decreased right ventricular ejection fraction, does it mean right ventricular dysfunction, or is just an afterload mismatch? How can you reconcile that?
Yeah, that's such an important question, and probably something I should address in as a slide in future talks. And thank you for that. I think this concept of RV PA uncoupling is an idea that I think is now being explored and studied further. And there are RV PA coupling parameters. So, for example, TAPC in relation to PASP. So those kinds of ratios, so like a non-invasive POPI for, as on echo, for example. So I think those are measures that are going to become increasingly useful for us to be able to, exactly as you said, understand the load impact on function and when this uncoupling occurs and at what point does that uncoupling occur. And so we actually have a paper that's currently being reviewed looking at this exact sort of concept, this compensation and the RVPA uncoupling. What are the threshold at which point we should be concerned? And I think in the future, we're going to be focused much more on these uncoupling parameters, the TAPC PASP ratio, for example, even on standard echoes. I mean, there are measurements we can derive on a standard echo, in terms of the value. So I think that's kind of where things are headed, being able to assess function in relation to these afterload increased states.
Thank you very much. Do you use the ratio of strain of the RV to the PASP? Do you find that useful?
Yeah, actually, there are the established cutoffs are more for the TAPC PASP, but we have looked at strain in relation to PASP, and that also works. Actually, probably better than TAPC PASP in some scenarios. GLS, I think, is just a much more sensitive tool, both for diagnosis and prognosis. And so I think when that's available, that's also incredibly handy as well, that GLS over PASP ratio.
Thank you very much. So we have a question from Daniel Lorenzati. He says, great lecture. Do you routinely include RV views in your CMR exams? And he says, what do you think of axial cine imaging for RV volume quantification, as it has been shown to be better in some scenarios like the trilogy of follow-up patients?
Yeah, that's a really wonderful question. Our standard MRI sequences are we do short axis LV and RV sequences for our standard clinical MRI exams. A lot of our, but for better or worse, for scanner time restraints, et cetera, we try to, as we talked about earlier, keep our throughput and efficiency as high as possible. But certainly, the long axis RV measurements can be incredibly helpful in congenital patients. So in congenital heart disease, we do add on a stack of 4 chambers. So we do that kind of more axial appearing RV look as a stack, but only for our congenital patients. Just as you said, for our TOFs, for our other complex congenital cases, we'll add it'll tax on 5 minutes or so. We're always talking in minutes and time when we add on additional sequences. But yeah, certainly, those views are incredibly helpful in some of our patient populations, and we do try to do them in specific populations.
Go ahead, Mario. You had a question?
Yeah, no, actually, somewhat related to the previous question I asked you, but in the opposite direction. Now we are more and more involved considering patients with significant tricuspid regurgitation for percutaneous device closure surgeries. Not been very successful in the past, but we think that we'll have a better chance with tricuspid repairs via catheter approaches. Do we have a good way of knowing when the ventricle is too far beyond? Because here is the opposite. We have a reduced afterload, and we tend to overestimate systolic function.
That's also, really wonderful question. I think that is a huge question. I know you have a really fantastic heart valve team at Monty. But I think that is still sort of an unknown question. At what point is the ventricle, is the damage sort of irreversible? I think in terms of key areas, people have looked at remodeling, people have looked at function, in terms of RV size and EF. People have looked at RV annular size, 3D models. But really, I think an area of interest that I'm really curious to see is the impact of fibrosis and infarct. Does that add incremental value? I don't think we're quite as sophisticated as we could be for predicting TR response after repair and replacement. And I think MRI adds so much, and so we've started looking at the QSM data in TR patients. Does oxygenation matter? Does fibrosis matter? And so I think MRI really gives us additional tools and additional parameters that we could be looking at.
Yeah, I know at least in AR, right, we have data that mapping helps a lot in establishing the prognosis. And with the RV, I think that's a caveat. Doing parametric mapping is probably impossible, right?
Incredibly difficult. I mean, there are papers out there that we've had difficulty replicating. If you're just doing a standard parametric map and you're trying to draw an ROI on a tiny, on a super thin structure, how reliable that number is, I think is up for question. We are working on some navigator-based techniques for parametric mapping as well, to really try to tailor our imaging for the RV. So many of these tools that we use are have been focused on the LV, that I think some of these tools we need to refine for the RV. We can't just apply the same technique and hope that it works the same way. But it's much more challenging in terms of mapping techniques for the RV.
Thank you. We have a question from Joao Cavalcante. He says, great talk. And he has any developments for a true 3D functional assessment by CMR akin to functional CTA?
No, I think it's also a fantastic question as well. So there's of course 4D flow in terms of RV hemodynamics and RV measurements. There are 3D. We've started using 3D navigator sequences for the RV. I think that's one technique, getting really high resolution navigator MRAs, if you will, for the RV. I think that sort of is a potential equivalent. And then, doing very thin slices, for the RV to get, really high resolution stacks of the RV. I think those are some potential strategies. But I think, there's more data in terms of 4D flow for TR and some of the functional analyses. And I think there's probably, there's more coming in that area as well.
Thank you. We have a question from Rob Osfeld. He says, are you aware of lifestyle changes such as diet, in particular foods that may increase nitric oxide, such as green leafy vegetables, beets, exercise, or treating OSA that can improve RV function?
That's a great question. That in terms of the RV is a really interesting and I think really a fascinating area of research, because I think how we improve RV function is limited. We have all these medications to improve LV function. We have things that help LV remodeling, that, there's years and years of data for the LV. For the RV, there's just far less. So are there, targeted medications and things like that improve RV function? They're far and few between, I think. And I think, that's an area, targeted therapies for the RV, for example, as I talked about for coronary disease. I think those are, definitely areas of interest that need to be studied further.
Thank you. We have another question from Daniel Lorenzati. It says, do you have any tips for assessing right ventricular LGE presence in non-ischemic cardiomyopathies like sarcoid or arrhythmogenic cardiomyopathy using out-of-the-box sequences?
That's a great question. We have tried. You have GE scanners at
we have GE and Philips.
And Philips, yeah. Some of the atrial targeted LGE sequences I found actually works pretty well for the RV. So GE has an LGE sequence tailored to look for atrial fibrosis. And so I've actually, it's an out of the box pulse sequence. for LG characterization of the atria. And I've actually found that to work reasonably for the RV as well. Sort of the concepts being similar, that the atria are thin and as is the RV. So that I think also works well. I think you can also look at the inversion times. You can look at your scout images and try to, the TI for the LV and RV may not be necessarily the same. And so if you're looking specifically for the RV, you can also, use one of the atrial tailored imaging. If you have even just an out of the box navigator pulse sequence, the spatial resolution and the contrast and noise ratio in general is much better for the navigator sequence as well. So that would be another technique. And then trying to tailor the TI to the RV, I think also helps.
That's great. I love these kind of questions for from experts like yourself. I think afterwards help people set up these protocols a lot. And just last question from Saul Rios, one of our fellows. When you're assessing LGE in the RV for revascularization, how do you report it, or how do you make your, do you make any comment or recommendation based on that for revasc?
Yeah, that's a great, that's sort of a data-free area. We do, when we read studies and we see RV infarction, we definitely comment on it. In terms of whether, do the same sort of principles apply, greater than 50% thickness, resulting in improved function post-revascularization. I don't think we have that data yet for the RV, but we do certainly make comments when we see these kinds of big RV infarcts, before patients undergo revascularization in our reports, and let our CAP colleagues know as well.
Okay, well, thank you very much. That was great. And hopefully we have you here in person soon, as we're very close. And so I'll see you shortly.
Wonderful. Thank you so much. Thanks everyone for joining. Really greatly appreciate the opportunity.